and comments, or in short, feedback in medical education. So this is our third part of a multi-part series of faculty development within the department, and really ties in nicely with what we've talked about the last two sessions. First time we talked about communication differences between various generations, and last time we talked about bringing the residents back to the bedside. So now we're talking about the end of the shift, or giving the feedback on the shift. So if we can go to the next slide. I've got no disclosures. Next slide. So two main objectives today. Broadly speaking, we're going to describe the role and characteristics of constructive feedback in medical education, and we're going to understand some of the common challenges and barriers to effective feedback. Next slide. So definition of feedback. Feedback is the sharing of information on actual performance to help guide the students, or in this case, residents, future performance towards the desired goal. In short, it's what we actually observe is what we're giving the feedback on for this definition. And it can be split into two different types. If we can go to the next slide. There's summative and formative feedback. Now, summative is what I do at the midpoint and at the end of the year with the residents, where I sit down, actually take some of your feedback that gets fed up to the core competency committee, a 360 evaluation where they're going to evaluate themselves and have other people in the department, including patients, evaluate themselves, and sit down and make some long-term goals. But what we're talking about here is the formative feedback, or what I would consider actually the more important feedback for the resident to get. And this is when we provide feedback to inform change and improve resident learning and performance. Next slide. So why is it important? Well, if you remember back from the first lecture, PICS or it didn't happen. We've got to label feedback. Along the same ways, trainees state that they receive inefficient feedback during their medical training. Doesn't mean that they don't always get feedback. It may not just be appropriately labeled. So again, as we talked about with the first lecture, make sure that you label the feedback when you give it to the residents so they know it's coming and they know what it is. The feedback has also been shown to change physicians' clinical performance when provided systematically over time or by an authoritative, credible source. For the purpose of this discussion, we're all the authoritative, credible sources here. It also can strengthen the teacher-learner relationship. When done properly, we actually can increase that bond with the resident and make a better experience, not only for them, but for us over the 3 years. Next slide. So establishing that respectful learning environment is the most important. I really like this quote from Tim Fargo, who's a motivational speaker and author, and he says the mistakes should be examined, learned from, and discarded, not dwelled upon and stored. In other words, when we're giving feedback, constructive feedback, we're pointing out to the resident what went wrong, potentially, how to fix it, and how to improve. We're going to talk about how to do that the rest of this, but I think one of the most important things here is not to dwell on it. If a mistake's made and we correct the action, and we get the desired action, there's no need to go back and remind them about the negative things that happened. If it continues to be a pattern despite the feedback that we give, that's a different issue. And that's one that needs to be brought up the ladder, brought to me, brought to somebody, one of the other faculty, and we need to direct it there because there may be a cognitive issue with that resident. But for the most part, a mistake happens, we correct it, we give an action plan and it's corrected. Forget about it. Move on. This is what's going to help establish that respectful learning environment. Feedback's not nearly as scary when you realize that it's not punitive, but it's an opportunity to grow. Next slide. So communicate goals and objectives for feedback. Label your feedback. Make sure that we point out exactly what we're going to do. It sets the stage for the resident, and it also keeps mind at ease. When they say, when you're talking about something that maybe didn't go right on a shift, but you start off explaining that this is a feedback session, this has the potential of being received much better by the resident, and by extension, it's going to be much easier for you to give that information to the resident to give the corrective action. Next slide. Make sure you base your feedback on direct observation. Ideally, the feedback given on shift should be about what happened on shift, not what you heard somebody else say, not something that you heard one of the nurses tell you they always do, they always say this, they always do this, they always give that. Make sure it's something you observe and can point back. If there's a pattern of behavior that we're concerned about, that's something different. That can be fed up. That can be handled with the summative feedback from myself or one of the mentors. But on shift, please try to stick with direct observations from that resident. And it keeps things much easier when having the discussions. Next slide. Make feedback timely and regular. At the end of the shift is a great time to talk about what happened on the shift. If you've got a series of shift with a resident, you might wait till the end of that stretch, especially with a more senior resident, to kind of say, hey, this is where you were, this is what we've talked about before, this is where you are now. But you don't need to mention something today that happened 6 months ago with that resident. If you didn't think of it at that point to talk to them about it, or you didn't think it was an issue at that point, no need to bring up the past then, especially if it's not an issue today. Again, if it's a pattern of behavior and that's what you're working on giving feedback on, that's fine if you give kind of a sequence. But if it's something that you've been dwelling on for that long, it probably should have been dealt with much sooner. Next slide. One of the best ways to start your feedback session with the resident is to ask them to give themselves a self-assessment. Now, you can see from the 6 pictures here, 6 completely different ways that a resident may think about what happened on the shift. You may have thought it was an awful shift, especially one particular patient interaction. But if the resident is telling you how great they did, that you're going to deal with that a lot different than if they say, God, you know, I felt really horrible about that interaction when I had to have the end of life discussion with the family. I really stumbled over my words. How do you handle this? The resident may be reaching out to you because they realize there's an issue as well. That's a very self-aware resident and one that you want to be dealing with. And frankly, makes for a much better opportunity. But if the assessment's off and they think that they're doing much better or performing at a much higher level than they actually are, the so-called Dunning-Kruger effect, then this is something that you need to really work on. And if this is a cognitive issue, again, move up to myself or one of the mentors of that resident so that we can start having a better way of helping that resident understand what's going on. The other important facet of self-assessment is it aids in making the resident more reflective, which makes them a more reflective physician. It helps them gain perspective on their career path, not only during residency, but longitudinally. And it also aids in having a two-way discussion with the resident. Instead of you just dictating everything that went right or wrong, you offer it up for a two-way discussion with the resident. And again, an opportunity for growth, an opportunity for mentorship, an opportunity to actually form that bond with the resident. And like I said, ultimately making a more enjoyable interaction for both you and the resident for not only that feedback session, but for the rest of your careers. Next slide. Reinforce and correct observed behaviors. So positive feedback first. It bolsters confidence in the resident. And then you want to highlight the corrective action after that. So, you know, giving back to that example of the resident saying, you know, I really felt that I stumbled over my words. The positive interaction may be that they recognize that they needed to have the discussion with the family about end-of-life care for this 95-year-old patient who is suffering, dying, and they, you know, either needed to be intubated or be made hospice. So recognizing that behavior is a good thing. Now, how they handled it, that's where the corrective action comes in. But once you focus and kind of anchor on the fact that they did right in realizing that the end of care discussion had to happen, that's where they're going to gain some confidence that they at least were going down the right path. Now the corrective action or the feedback is going to be how to make those words a lot easier, or how you handle the discussion as an example, so that they may learn. Next slide, please. What you want to avoid is the so-called poop sandwich, or if we weren't being recorded, a little more harsh language there. And what this is a very weak, positive followed by the negative comment, followed by a very weak positive. So I like the way you always come dressed in a crisp white coat, but the way you talk to patients are awful, and your scrubs are always nicely pressed. It's not a very good way of handling feedback, but unfortunately, when we get this idea that we have to say something positive, negative, and positive, it can turn into this poop sandwich. Avoid that. Really look and see what the patient or what the resident did positive, anchor on that, and then make your corrective actions after that. Next slide. With the right resident, especially one that's self-aware, this 4-step process can be very helpful. Ask the resident what they did well. And when they tell you what they did well, you can agree as appropriate and add any reinforcement comments. Then you can ask them to self-identify the areas of improvement. And if they're correct on their own areas of improvement, that's great, and you can agree with them and modify as needed. But this 4-step process, again, offers that dialogue with the resident, gets them involved in their own corrective actions, and also lets them kind of figure out where they need to improve. And if they can start doing this as a PGY1 all the way through PGY3, when they leave as a attending, they're going to continue this self-reflective behavior, and potentially you're going to impact a resident or affect a resident to have a very reflective, positive career for the rest of their career. Next slide, please. You want to make sure that you use specific neutral language to focus on performance, but try not to keep it vague. Just as this shark is looking at the minnow, you don't know whether or not the shark wants to eat the minnow or teach it how to swim a little bit better. Use your language appropriately. Don't be harsh. Sit down at their level. Make sure that there's good eye contact. If they're standing, you should stand, or better yet, offer them to sit while you sit. Keep open body language. Keep things positive while talking to the resident, even if what needs to be said may be construed as negative. Next slide, please. Most important, confirm the learner's understanding and facilitate acceptance of what's being said. You want them to listen to you. You want them to restate meaning in what you said, and you want to confirm the understanding that they have. And this is a tool that not only works very well with residents, but for those of you that are parents with kids also. I've got a son that's in honors math, and he had a little slip at the end of last semester, and his A went to a B. And I sat him down and said, listen, this year it doesn't count, but next year, even though you're still in middle school, those grades are going to count for your high school transcripts, and the grades you have will follow you the rest of your high school career and impact you going into college. When we were finished talking, I asked him if he understood what I said, and he said, yeah, you said I'm a failure and I'm not going to get into college. Far from what I said. He was. So we had to kind of go back and redefine what was said. I had to make sure that he understood what the effect of his actions would be next year when he was in math class, and how big of a deal it was between an 89% and a 90% being a B+ and an A, and the effect on his GPA. And after we were done, he understood and didn't think that he was a bum and not going to get into college anymore. But it was really sitting him down and making sure that what I said and what I meant was what he heard. It's amazing. The negative feedback that residents get and anybody gets is more important than the positive feedback, and it hits harder. I gave a grand rounds early in the year and had over 100 participants and had a approval rating of 4.9 out of 5. I was very happy with it. Where did my eyes go with the comments? Right down to the negative ones. Instantly, I wanted to figure out how I could fix all of those negative comments. It hits hard, but you need to make sure that when it hits hard, that it hits appropriately. And taking this step to make sure that they understand what you're saying and not reinterpreting what you're saying is so key in making sure that the feedback goes smooth. Next slide. So finally, conclude with an action plan. And this isn't necessarily, this is a on the fly, while you're on the end of a shift action plan. So I'm not talking about sitting down, writing out a formal plan that you're going to go back and check and recheck. What I'm talking about is this is where we see the defect. This is how I recommend you follow, how you improve it. This is what I would do in the future. And again, making sure they understand where that step is. Chances are you're going to have another shift with that resident in the near future. And you can see if when that same behavior comes up, if they improve on it. And if they do, make sure that you point it out to them. Make sure you have that positive reinforcement as much as that negative. Next slide, please. Sorry. Finally, make sure that feedback is part of the institutional culture. This July, we're starting off with the new residents. And we've never had the residents before, our own residents before in the hospital here at Broward Health North, and EM residents at all within Broward Health. So as we grow this culture of education, we can make feedback part of that culture. If feedback is part of the culture for the residents, not only will they appreciate it and expect it, it will not only and foster a good relationship between us and the residents. It'll make those negative experiences with feedback, or when you have to correct an action, that much smoother, because the residents will expect the feedback to happen, and it'll be a non-punitive way to make that occur. So I really hope that as we gear up waiting for the residents to start, that we can incorporate this idea that feedback is going to be part of our culture. Next slide. So, like anything else, there's always some barriers to good feedback. Next slide. The first is that little to no instruction is given on how to give feedback. And that's the purpose of this whole, not only just this talk, but these series of talks leading up to the residents coming. I'm hoping that you guys are feeling like you're getting a playbook to help aid in the resident experience that's going to be coming up and that we're all going to go into together. If at any point anything that I'm saying isn't making sense, or you want to focus on something else that we're doing, please let me know. Give me some feedback so that we can better prepare our playbook for the residents to come. And once they do come, let me know what we need work on, and I'm more than happy, if I can't provide it specifically, finding us the resources to help doing this. Next slide, please. Another barrier is sometimes fear of damaging the relationship with the learners. It's natural for people to want to be liked and to like other people. Understand that this is a teacher-student relationship at its crux. We are responsible for making sure that the residents learn. On the same side, the residents want to be taught. Feedback is a positive thing, even when what's being corrected is negative. It's all in how you frame it and all in how you deal with it. If we're adult, if we're honest, if we're upfront, the residents will benefit from our feedback. We will not damage a relationship with the residents, but instead foster a relationship with the residents. Feedback is key. Next slide, please. Other issues are cultural context issues. The norms of communication vary between cultures, such as personal space. It can be important to find common grounds in these situations. And along the same lines, there's this idea of cultural noise, or people may form assumptions based on stereotypes of other people's cultures. One of the beauties of medicine is that we've dealt with so many different people, so many different cultures, just naturally through our careers, that we should be able to go right through these cultural context issues. Innately, we should understand if there's any issues, we can address these as they come up. But we deal with different attendings, different in primary care as well as in subspecialty care. We should be able to deal with residents regardless of cultural context. So, but again, if there's any issues, please let me know. Next slide. One of the biggest one is the student's ability to self-assess. And I actually have a whole presentation on this idea. The majority of physicians, unfortunately, are poor self-assessors, with the least skilled overrating themselves. It's this Dunning-Kruger effect. And really, if we start off by asking the resident to self-assess and see that they're way off, it's actually a good jump-off point. I'll never forget a resident coming into me when he was a PGY1, and he asked me, I asked him how everything was going, and he said, great. I've done 5 intubations, so I'm good with that. Now I can move on to LPs. And I said, what do you mean you're good with that? He's like, yeah, I got them all. And so it led to a discussion about how people's self of own skill set can be a little inflated after a couple of positive experiences, and how that one negative experience may bring him crashing back to earth. And it led to a nice discussion, and I think it kind of reared him in better. And over time, he became better at self-assessing. But it did take time to work with him, and he definitely suffered from this Dunning-Kruger effect. As they improve their self-assessment, they'll have increased motivation, increased and improved knowledge, communication, and performance. So really taking this time to make sure that they learn to self-assess is important. Next slide. So in conclusion, these were the topics that we talked about for the importance of giving good feedback: establishing the meaningful learning environment, communicating goals and objectives, base feedback on direct observation, make the feedback timely and regular, begin the session with self-assessment, no matter how tough that may be, reinforcing correct and observed behavior while avoiding the poop sandwich, using specific and neutral language to focus on performance, confirm the learner's understanding and facilitate acceptance, conclude with an action plan, and we're going to make feedback part of our institutional culture. Next slide. But beware the barriers and learn how to overcome them. And let's not forget the words of Ed Batista: make feedback normal, not a performance review. Next slide. If there's any questions, I'm happy to take them. And the slide after this is actually a list of references, which will be available on our Teams app. So if anybody wants to read more about any of these things, it's all there. Thank you for your time.
The lecture was already uploaded to Teams. If you guys are having a problem, not Joanne and Krista, but if anybody else is having a problem getting to the Teams site, let me know. All right, any questions for Dr. Bain? No? All right, thanks, Kevin.
Thank you, Caesar.
Appreciate it.
My pleasure.